Thanks so much to everyone for joining us for today's pneumococcal vaccine session. I first wanted to take a moment to thank our incredible work group members who have really stuck by us through a series of rapid-fire meetings that have been escalating over the past year as we've come closer and closer to this decision that we have to make today. Special thanks to Kip Talbot and Paul Hunter, who are our ACIP members on the pneumococcal vaccine work group, and a huge shout out to Almia Madanaka and Tamara Pilishvili, who've been amazing leaders in this work for us. Our liaison representatives, and I look to those of you who are in the room today who are also on the work group, and also would appreciate your engagement in the conversation around today's discussion. Have been terrific about providing their input in a really thoughtful and respectful manner. It's been a really challenging set of conversations, but one I feel that in terms of process, the work group has done a tremendous job with. Our terms of reference were to review the current data on the efficacy, effectiveness, immunogenicity, and cost-effectiveness of the pneumococcal vaccines, and to review current recommendations, i.e. The 2014 recommendations, considering up-to-date evidence, including epidemiologic studies, and to assess the strength of that evidence, and to revise or update the recommendations for pneumococcal vaccine use as needed. As a reminder, PCV13 became available for use in children in 2010. In 2012, there was a recommendation for PCV13 given to individuals 19 and older with immunocompromising conditions. And then in 2014, there was a decision to give PCV13 in series with the polysaccharide vaccine, PPSV23, for adults 65 and older. And we are currently reevaluating that 2014 decision. When that recommendation was made for recommending PCV13 in series with PPSV23 for adults 65 and older, the rationale was that the recommendation was warranted in the short term because there was still a significant burden of disease among older adults, and particularly due to pneumococcal pneumonia. The public health benefits in the long term, however, were expected to be limited since the indirect effects from pediatric PCV13 use were expected to increase. Thus, the recommendation was made with a commitment to reevaluate this policy, and that's how we got here today. So the policy question is, should PCV13 be administered routinely to all immunocompetent adults ages 65 and older in the context of indirect effects from pediatric PCV13 use experienced to date? Again, our population to focus on are the immunocompetent adults 65 and older. The intervention is PCV13 in series with PPSV23 in the context of indirect effects. The comparison is PPSV23 alone, so emphasizing that we will continue to recommend PPSV23 for the adults in the context of indirect effects. And the outcomes are invasive pneumococcal disease, pneumonia, mortality, and safety. Now, the recommendation was for all adults 65 and older, but we wanted to highlight that the policy question really does focus on the immunocompetent adults 65 and older because we are not including in the current policy discussion adults 19 and older with an immunocompromising condition, including any of the below listed here. Those individuals would still receive a recommendation to get PCV13 in series with PPSV23 based on the 2012 recommendations by ACIP. So, it went off. So in terms of where we are today, there are three proposed policy options for today's vote. Number one, that ACIP recommends PCV13 for all adults 65 and older who have not previously received PCV13. In this instance, PCV13 should be given first, followed by a dose of PPSV23. So this would be the 2014 recommendations as is currently stated. The second policy option would be to consider PCV13 based on shared clinical decision-making for adults 65 and older who do not have an immunocompromising condition and who have not previously received PCV13. All those adults should receive, 65 and older should receive a dose of PPSV23. And the third option is ACIP no longer recommends PCV13 for adults 65 and older who do not have an immunocompromising condition. All those adults should receive a dose of PPSV23. So option A is continue the current policy from 2014. Option C is go back to the pre-2014 policy. And option B is shared clinical decision-making. And I'll just briefly walk you through the work group rationale for sort of how we got to this place. So our goal, as a reminder, was to reevaluate the 2014 policy to recommend PCV13 in series with PPSV23 for the adults 65 and older. So we started with this thinking about continuing the 2014 recommendation and thought that the answer should be a yes or a no. And we had proposed to initially focus on, or we do propose to initially focus on whether to continue the current recommendation or not, since that is a goal of our reevaluation. However, when we had further discussions with our work group, we recognized that no could mean two different things, which is shared clinical decision-making or no longer recommend. I'm hopeful that today, both through the presentations that Dr. Madinock will provide, but also through the discussion, that you'll be able to hear the diversity of opinions on the work group, of which I would say that the work group was split amongst the three different options, and there was no clear consensus going forward because this is such a complex decision. So in today's session, we will first discuss considerations for PCV13 use among adults 65 and older, and a summary of the evidence to recommendations by Dr. Almia Madinock, and the proposed policy options. And again, we'll go through the logic of some of those proposed policy options for discussion today. We did, at the last meeting, Dr. Massonnier asked for feedback from our liaisons and ex officio members on the policy options proposed, and we do appreciate the input that you'll provide today. And as well as then have a discussion about the considerations for PCV13 use among adults 65 and older. So thank you very much, and we look forward to the discussion. Dr. Madinock. Okay.
Thank you, Dr. Lee. So we'll move forward then with Dr. Madinock's presentation on considerations for PCV13 use among adults 65 years or older, and summary of the evidence to recommendations framework. Dr. Madinock.
Thanks. Thank you. As Grace mentioned, today I'm going to first discuss the considerations for PCV13 use amongst older adults and then summarize the ETR. In reevaluating PCV13 use, we have asked three key questions. First, what indirect effects from pediatric PCV13 use were observed among older adults before 2014? Then what effects from PCV13 use have we observed among adults aged 65 years and older since 2014? And what additional benefits do we expect from continued PCV13 use amongst older adults given the remaining disease burden? As Grace just mentioned, we are discussing adults 65 years and older without immunocompromising conditions. Adults 19 years and older with one of the following immunocompromising conditions are recommended to receive PCV13 in series with PPSV23 per the 2012 policy. This policy is not under the current reevaluation, or not part of the current reevaluation. So first, what indirect effects from pediatric PCV13 use were observed among older adults before 2014? Since PCV's first introduction in 2000, we have observed a 9-fold reduction in PCV13 type IPD, including a 3-fold reduction after PCV13 introduction for children in 2010. The graph depicts these declines. PCV13 type disease is in orange, with the incidence declining through indirect effects from 45 per 100,000 before 2000 to 5 per 100,000 in 2014. Reductions in all-cause pneumonia were demonstrated after pediatric PCV7 introduction in 2000. An analysis of HCUP data between 2010 and 2014 presented to ACIP did not observe any reductions in all-cause pneumonia, but demonstrated that there were declines from indirect effects in pneumococcal pneumonia of 35% for adults 65 to 74 years old and 20% for adults 75 years and older. As asked at the last ACIP meeting, what have been the indirect effects from pediatric PCV13 use observed amongst older adults by age, race, ethnicity, and underlying medical condition? Depicted on this graph are the trends in PCV13 type IPD by age group, starting with the lowest incidence in adults 50 to 64 years old, represented by the solid light blue line, up to the incidence in 85 years and older, represented as the dotted dark blue line. Indirect effects have been observed in all age groups, reducing but not eliminating disparities by age for PCV13 type disease. Similarly, for indirect effects by race and ethnicity, PCV13 type IPD has been reduced among adults of Black race as depicted in the upper left-hand graph, Navajos as depicted in the upper right-hand graph, and Alaska Natives as depicted in the lower left-hand graph. For Alaska Natives and Navajos, as compared to the general population, disparities in PCV13 type disease have been reduced, but also not eliminated. Lastly, indirect effects amongst those with and without chronic medical conditions are shown here. To highlight the PCV13 type, there has been a similar percent reduction in PCV13 type disease amongst adults 65 years and older with chronic medical conditions, including chronic heart, lung, and liver disease, diabetes, alcohol abuse, and those who smoke cigarettes, as compared to healthy adults. Next, for PCV13, individual level effectiveness and PCV13 safety. In 2014, we knew that PCV13 was efficacious in preventing IPD and non-bacteremic pneumonia. Results from the CAPITA trial were 75% VE for PCV13 type IPD and 45% for PCV13 type non-bacteremic pneumonia. Additionally, PCV13 safety had been demonstrated in clinical trials. In 2014, the GRADE evaluation demonstrated a strong quality of evidence. We incorporated post-licensure data into GRADE this year and reached similar conclusions about PCV's benefits and harms. PCV13 is effective against PCV13 type IPD with a VE of 47 to 75%, PCV13 type non-bacteremic pneumonia VE of 38 to 71%, and all-cause pneumonia VE of 6 to 11%. There is limited data for PCV13 type disease mortality, but no VE has been demonstrated for this outcome. For harms, examining serious adverse events associated with PCV13, we have not observed any concerning safety signals. Moving from individual level effectiveness data to population level impact, it is important to first understand what the vaccine uptake has been. PCV13 coverage shown here in the brown bars is now 47%, with 30% of adults 65 years and older having received both PCV13 and PPSV23 shown in gray. The years of data that we are discussing here for the most part are 2016 and 2017. So I just wanted to point out that the coverage then was 36% to 43% for PCV13. Since 2014, what have been the population level impacts on disease? Or in other words, what has been the combined direct and indirect effects? Examining IPD incidence amongst adults 65 years and older, in blue is all IPD, in gray is non-PCV13 types, and in orange is PCV13 types. There has been no population-level impact on PCV13 type IPD since 2014, i.e., we have not observed continued indirect or direct effects at the population level. Additionally, now non-PCV13 serotypes make up the majority of disease burden. Examining PCV13 type IPD mortality among adults 65 years and older, in blue is all IPD mortality, and in orange again is PCV13 type mortality. The orange bars here represent the annual PCV13 type IPD case fatality ratios. There has been no population level impact on mortality associated with PCV13 type IPD since 2014, and no change in the case fatality ratio. We evaluated trends in non-invasive pneumococcal pneumonia incidence from CDC's surveillance for non-invasive pneumonia, the graph on the right. We compared non-invasive pneumonia to invasive pneumococcal pneumonia incidence from ABC's, the graph on the left. The trends in the two are similar. Additionally depicted here are the rates for adults 50 to 64 years old in light blue and those 65 years and older in dark blue. Incidence is higher for adults 65 years and older, but the trend in the two groups is similar. We observed a decline in non-invasive pneumonia between 2013 and 2014 during a period of only indirect effects, but have not seen any further population-level impact on non-invasive or invasive pneumonia since 2014. A population level impact was observed in the Pfizer Louisville cohort study. Reductions of 31.5% in PCV13 type pneumonia and 13.8% for all-cause pneumonia were demonstrated between 2014-15 year and the 2015-16 year. PCV13 type pneumonia was 4% of all-cause pneumonia versus the 10% that it was estimated to be in 2014. So next, what additional benefits are expected from continued PCV13 use amongst older adults given the remaining disease burden? First, what is the current PCV13 preventable disease burden? PCV13 type disease has remained stable since 2014. For IPD has remained stable since 2014 with an incidence of 5 per 100,000, representing 20% of all IPD. Serotype 3 is not only the most common PCV13 serotype, but also the most common overall for IPD. For PCV13 type pneumonia, our incidence ranges from 17 per 100,000 to 76 per 100,000. 17 comes from CDC's non-invasive pneumococcal pneumonia surveillance, assuming 20% of all pneumococcal pneumonia is caused by PCV13 types. And 76 is from Pfizer's Louisville cohort study, where they are able to measure the proportion directly using a serotype-specific urine antigen test. Again, PCV13 type pneumococcal pneumonia is 4% of all cause pneumonia, and serotype 3 is the most common. Here are two economic models which estimate the public health impact and cost effectiveness of PCV in series with PPSV as compared to PPSV 23 alone. For the CDC model, we included two different assumptions about the effectiveness of PCV13 against serotype 3 disease. The estimated cases averted for PCV13 type IPD are 76 to 175 cases, and for PCV13 type pneumonia are 4,000 to almost 11,000 cases in a single cohort of 65-year-olds. So I'm just highlighting for IPD and for pneumonia, the two grouped together. Applying the cost to quality adjusted life years, the estimated cost effectiveness ratios are between $200,000 and $560,000 per quali. The annual numbers needed to vaccinate for adults 65 years and older would be 26,000 vaccinated to prevent one case of IPD, and 3,000 to 14,000 vaccinated to prevent one case of inpatient pneumonia, and 2,600 vaccinated to prevent one case of outpatient pneumonia per year. We had a few additional important considerations from the evidence to recommendations framework. First, the values and preferences of older adults regarding PCV13 use. There is limited data for this element. In 3 patient-focused studies, participants perceived pneumonia as severe and sometimes fatal. However, there was low perceived personal susceptibility to pneumonia. The work group's perspective was that the potential protection against pneumonia likely outweighs the effects of PCV13 for older adults. There's also limited data on assessing acceptability among stakeholders, but from the studies we reviewed, some found that providers still found the current recommendations confusing, and for some, reimbursement for vaccine was still a programmatic issue. However, in other studies, providers recommended continuing with the current recommendation. This was also noted to be a preference programmatically if higher valency conjugate vaccines were going to be available soon. In addition to these study results, the work group also noted that frequent changes in recommendations may negatively impact the perceived importance of future adult vaccine recommendations. And on one side of the argument, continued PCV13 use provides individual level protection for the remaining PCV13 type disease burden. But on the other side of the argument, continued PCV13 use provides minimal public health benefit due to the remaining disease burden. When considering feasibility, the following issues were raised. The current recommendations are complex, but have been integrated into many healthcare and public health systems. Frequent changes to recommendations could present implementation challenges. Universal age-based recommendations are easier to effectively implement than risk-based recommendations. And lastly, that effective communication strategies will be needed if a policy change occurs. So in summary, these are the key issues in favor of continuing in the first column and reasons for discontinuing PCV13 use in the second column. Looking at the burden of disease, indirect effects from pediatric PCV use have reduced the burden of PCV13 type disease to historic lows. However, PCV13 type disease, while reduced, has not been eliminated. In terms of benefits, PCV13 is effective in preventing PCV13 type pneumococcal disease, but impact from PCV13 use in older adults observed to date is minimal. There has been no impact on IPD observed, and there has been inconsistent findings across studies for the impact on pneumonia. The benefits from continued PCV13 use are expected to be minimal. For acceptability, as mentioned, frequent changes in recommendations may negatively impact the perceived importance of future adult vaccine recommendations, favoring keeping the current recommendations. However, credibility comes from strong scientific evidence-based recommendations, which, given the remaining disease burden and lack of consistent population impact, favors no longer recommending PCV13. In terms of the resources used, a recommendation change would incur a cost to update electronic medical records and decision support tools. But the results of the economic analysis do not favor continued PCV13 use. Lastly, feasibility. Frequent changes in recommendations present implementation challenges, and universal prevention strategies are easier to implement effectively. However, discontinuing PCV13 would simplify what have been confusing and difficult to implement recommendations. So, in summary, the work group agrees that by far PCV's greatest impact for adults has been through indirect effects from pediatric use. Since 2014, we have not observed consistent population-level impacts from PCV13 use amongst older adults. and continuing PCV13 would not be cost-effective by usual standards. On the other hand, frequent changes in recommendations may negatively impact the perceived importance of adult pneumococcal vaccine programs and present implementation challenges. Some work group members weighed more heavily the former strong scientific rationale in favor of changing the recommendation, while others weighed more heavily the latter acceptability and feasibility issues in favor of maintaining the current recommendation. Maybe that's all. The three policy options that the work group considered were recommend PCV13. ACIP, and the language is as ACIP recommends PCV13 for all adults 65 years or older who have not previously received PCV13. PCV13 should be given first, followed by a dose of PPSV23. Alternatively, a shared clinical decision-making. ACIP recommends PCV13 based on shared clinical decision-making for adults 65 years and older who do not have an immunocompromising condition and who have not previously received PCV13. All adults 65 years and older should receive a dose of PPSV23. And then no longer recommend PCV13. ACIP no longer recommends PCV13 for adults 65 years and older who do not have an immunocompromising condition. All adults 65 years and older should receive a dose of PPSV23. The guidance for PCV13 and PPSV23 use based on the proposed policy options would be the same as it currently is if the recommendation is unchanged. If PCV13 is instead recommended based on shared clinical decision-making, the guidance would be updated to reflect options with and without PCV13. And if PCV13 is no longer recommended, the guidance would revert to what it was before the 2014 recommendation was made. So that's where I had stopped and just have those options up on the slide still for the discussion.
Thank you very much for testing. Yep. Thank you very much for that presentation, Dr. Manotok. So we're going to open it up to the voting members for comments and questions. Dr. Szilagyi.
Okay. Is that on? Okay. Okay, thank you. First of all, wonderful. You always make complex areas feel much simpler, and your presentations are great. I just had a couple maybe questions or comments, both about shared decision-making in this context for this vaccine and the challenges in clinical practice. So it seems to me that shared decision-making in this context, for these are immunocompetent adults over 65, doesn't depend on an observable behavior or something that you can get from an interview, which is actually very different from the last discussion we had. And I'm trying to figure out what guidance would be offered in shared decision-making for clinicians other than values, a sort of patient values. And my other comment was, it feels to me as a clinician, and I'm a primary care physician, although I don't take care of adults, that simplifying something is less disruptive and less of a challenge than adding a vaccine or adding something. So I recognize the challenges and the potential concerns for the future, but it seems to me that this is less of a challenge than sort of other decisions we made.
Thank you, Dr. Fry.
I just was going to ask the same first question that Dr. Szilagyi has asked. I'm a little confused about how shared decision-making would be made with this particular vaccine.
Dr. Walter.
I, too, was questioning the same thing. And maybe Grace could tell us a little bit what the work group was thinking with the shared decision-making and how you expected that conversation to roll.
I will say, and I invite the other members of the work group to chime in. I'll just speak from my own opinion for the moment. But in terms of shared clinical decision-making, I think there was a recognition, as we have discussed earlier, that the population-level benefit is minimal in the context of indirect effects from the pediatric vaccination program, and that the pediatric vaccination program is really what's been the most impactful on adult burden of disease. So with that said, there is also a recognition that there is some individual benefit to patients who may be exposed to PCV13 type pneumonia. The challenge being obviously that the burden of disease due to PCV13 specific serotypes is low compared to all-cause pneumonia. So I think that particular construct came up because of this tension we were having between population-level decision-making versus individual-level decision-making. And then just one more thing. And then just, there's also, I think, the challenge of recognizing that there are, it's a challenge because it's a distinction between like a risk-based recommendation versus shared clinical decision-making. And I think we're actually sort of unpacking this construct today as we go, and so I invite you to weigh in and comment on it. But I can imagine that there are certain populations, for example, Dr. Madanock shared in certain populations such as the American Indian, Alaskan Native population, where you might say, that latitude in decision-making may be appropriate to think about populations where they have higher endemic risk, and in that situation, it would make sense for a clinician to want to go ahead and target that particular population.
Go ahead.
Thank you. I think, there is always going to be this challenge about population-based benefit and individual-based benefit for vaccines. And I think you are always going to find some group, some population, however small, that is of benefit for. And I don't think when ACIP says do not recommend, that ACIP is passing a judgment on whether A, that the vaccine is effective, or B, that the small percentage of people that may be affected are not worth it. I don't think that's what ACIP recommendation is passing a judgment on. But I think what we are tasked at ACIP is to look at the bigger picture and look at the larger perspective and whether does it draw away from the target. When we are chasing a small one, does it draw away from the target? So that question comes in when we have unlimited resources. When vaccine is available and everybody can have it, I think everybody should have an opportunity, including the one person that it might effective to. But when doing those vaccines draw away from the target population, which sometimes the world is a global place, and we could have understood from the last comments when we expand some of those, what I would consider smaller population, that we draw away from vaccine who cannot actually start this vaccination because it's not available to them. There is a shift that happens globally when we make this recommendation for a smaller group of people, that we actually pull from a very large group of people that needs the vaccine to a smaller group of people that did that. And I think in the end, we are not doing the general public good. That we want to make sure that Thank you. And when it's targeted to those populations, so the whole idea I want to ask in this question again that I would ask in the other thing is that, is there an anticipated shortage in this vaccine? Because it should be able to help us in making decisions. Is our focus on this group, will it draw away from the primary general target population, which is the pediatric case? And I was wondering if there is vaccine shortage that is present or that is anticipated.
Thank you. Dr. Walter?
Sorry.
There you go.
We're passing. We have one each side.
So I think, what you said about, an individual population, then it really falls back to the provider, I think, and the strength of the provider recommendation more than a shared decision-making in this case. That's kind of how I would Because it's not a risk assessment with a patient. It really is a provider assessment for their practice in this case.
Dr. Szilagyi.
No, I didn't.
No.
So a couple thoughts along the lines. It is easier to remove something. It makes it simpler, but we are looking at newer and better and more comprehensive conjugate vaccines in the near future. And so it may become more complicated to remove and then try to add back. So that's one of the thoughts. The second thought is along those lines of adding back. Adults over 65 are not immunocompromised, although they do have some immune senescence, and that the conjugate vaccines provide B and T cell responses. Anyone in the room could talk about. Dr. Stevens could do better than me. And that removing the conjugate and allowing just the polysaccharide will blunt the future conjugate responses. And so I worry about removing that from an immunologic standpoint for a period of time and leaving a population naive. But
Dr. Atmar.
can he comment on my comment first?
Dr. Stevens, please.
So we've had this discussion previously about prime boost strategy and how that may benefit a future platform. I do think, and one of my questions actually is, where do we stand? Update us, if you will, on the future multivalent, expanded valent conjugates. That's one question. I do absolutely agree with Kip in terms of what is immunocompromised. We, in fact, 65-year-old with diabetes or COPD would be considered to be immunocompetent in this particular group, which in my view is not right, if you will, as opposed to a 30-year-old immunocompetent. I think we need to consider that in this discussion. One other point is about one of the challenges has been getting any vaccine into the adult population, into this population. If you look at the data that you presented on one of your graphs, with the polysaccharide alone, it was what, 45% or so was vaccinated of the eligible group. And now we're at what, 50, almost 60% with the combination of that. So we've actually made some progress in at least getting a vaccine into the adult population with the current platform. So those are a few comments. I don't know if I've particularly answered your question, but certainly support your comment.
We're going to hold on the questions here until we have all the comments. Dr. Atmar, did you have?
Well, so one of the things I wanted to address was the question Dr. Stevens asked, which is when the availability of the new conjugate vaccines will become available. And because it seems to me that this is the kind of discussion about, a vaccine that doesn't appear to have a public health impact in this population based on the information that's been presented. But there are clear data, and the Louisville data is an example, where efficacy or effectiveness of the vaccine in the vaccinated population is present. So in terms of shared decision-making, it's basically the clinician talking to their patient saying, here's a vaccine that's effective. It's not routinely recommended for your age group, and just have a discussion about pneumonia in general, and do you want this vaccine? It's an individual decision, and maybe some clinicians are going to push it more than other clinicians. But this is so. The default is shared decision making once the vaccine is licensed, but we're actually stepping back with a decision to go to shared decision making from what the current recommendations are. So I don't think vaccine availability is going to be an issue. And yet I can't see, because of the effectiveness data, going all the way to the last recommendation, which is no longer recommended because it's clearly effective when used in certain individuals. And so for me, it's, I'm moving towards more the second option. But I could be strongly swayed by the implementation issues if a new significantly higher multivalent vaccine is going to become available shortly, because I recognize that's an important consideration.
Dr. Hunter.
So I've got a couple of points. I don't see how things are going to change if we have higher valent vaccines. They're still going to work better if you give them to kids and protect the adults more if you give them to kids than if you gave them directly to the adults. I don't see how that data is going to change. The other thing is that I'm very concerned that as a clinician for the past 19 years, and now a public health practitioner for the past 10, I've gone from looking at making decisions based on individual patient characteristics and how my clinic personally operates to looking at a wide variation of clinical practice styles and quality in practice styles across the community and across the country when I go out and give presentations. And I've come to recognize that what really influences decisions that clinicians make and patients make is the policies that we set up, especially the insurance decisions that are made, and that those can have population level effects. I'm concerned as somebody who was in the minority on 2 of the 3 preferential votes that went in favor of the recombinant zoster vaccine, that I've watched with concern as the unexpected lack of supply of that vaccine has had, not rather than the increased pain that I was more concerned about, has resulted what I thought was going to happen, which was that they were going to be missing that second dose of vaccine. That has come to fruition. So this is all in my head as I'm thinking about my concern about, for both PCV and HPV, that emphasizing vaccines for adults over the vaccinating children will divert resources to the less beneficial, more expensive interventions. And if we don't have clear guidance or suggestions to clinicians about how to do the individual clinical decision-making, or shared guidance for patients also, vaccine manufacturers are going to have a vested interest in using their significant resources to educate clinicians and patients in a way that might not align with public health goals. Unfortunately, there are also significant resources that give information that are directed towards parents of children that is emotionally convincing to them to not choose to vaccinate children, which is actually going to also detract from the most benefit that can come from these vaccines. So I think we just need to be realistic of what we're deciding here, and not just focus on the individual and the patient-by-patient decisions that we're making.
Thank you, Dr. Bernstein.
The indirect effects of the PCV13 program, pediatric program, on adults 65 and older is really impressive. One question that I had is, are there data, should the rates of immunization in children for PCV13 actually go down as opposed to whatever they are now? How that might impact adults 65 and older?
Okay, so any other comments from Dr. Moore?
Thank you. I am still thinking very hard about the decisions. One of the numbers that really hit me, though, is the number needed to vaccinate. To prevent one case of IPD, it was an estimated 26,300 people 65 and older to prevent one invasive pneumococcal disease case. And those numbers are so incredibly high. My thought is that shared clinical decision-making reflects an uneasiness about dismantling the PCV 13 program as it exists currently, although perhaps a clearer risk-based, as much as I loathe risk-based recommendations, a more decisive risk-based recommendation might be more appropriate in terms of its ability to prevent disease in that group. And I share Peter's thought that it's easier to remove the vaccine for a time and introduce a new higher valent vaccine at a later date in the near future to that population than it is to maintain complex recommendations that have been quite difficult to implement. It's simplifying a recommendation is not as hard as making it more complex. So those are some reflections that I had on that. And one of the things that I have been worried about is that if we maintain a 13 recommendation until a higher valent vaccine comes out, would those older adults who had received 13 be recommended to receive the higher valent vaccine also? Or would they be passed over because they'd already received a different conjugate vaccine? And those are unknowable answers, but those are thoughts that I'd had in trying to weigh these decisions.
I was just going to, apparently, Grace, you have a backup slide on that's entitled Near Future Pneumococcal Conjugate Vaccines that might be good to put up. As I understand it, what we can say from the companies is that they expect to submit by the end of the year.
I think, and
I'll bring it up. Thanks,
okay.
yeah.
I mean, I think those were based on clinicaltrials.gov website, so I don't think they indicate real-time updates. And to Dr. Atmar's point, I think the question is like, if this were going to come back to us in another 9 to 12 months, I think, yeah.
What I would say is that all the companies can tell us is when they plan to submit to FDA.
Mm-hmm.
How long things take after that, as we know, is not something that's knowable. So I think that this
Correct,
is the
yes.
state of what one could know.
But I guess the question is this still true? Yeah.
We've asked them before.
Could I ask to see if the Pfizer representative, Dr. Luis Jordar, would like to make comment?
Hi, this is Luis Jordar. I'm the Chief Medical Officer for Pfizer. Thank you for the opportunity. The answer is yes. We've stated publicly we are now in phase 3 clinical programs for the 20-valent, and we've stated publicly that we are going to file to the FDA by the end of 2020. Again, I think something that I'd like to emphasize is that the FDA has given breakthrough therapy designation to the PCV20 for adults, so that might shorten, and perhaps the FDA representative may comment of that. The second thing about this is that there should not be too much skepticism about the filing dates or the approval dates, because these vaccines are based on immunogenicity and non-inferiority. And after phase 2, you already know what are the kind of responses that common serotypes and additional serotypes have. So at the end of the day, timing, in terms of timing, this is not a case-acquired clinical trial. This is something that requires exclusively safety, obviously, and immunogenicity assessments. Since I have the microphone, I'd like to just make a slight comment about the comment that was said about having the same sort of effect on PCV20 like PCV13 in terms of herd effects. If you introduce PCV20, shouldn't you have the same effects on herd effects? Just to reiterate that at least PCV20, and my colleague is going to talk about PCV15, it's going to be licensed in adults first. And it's going to take a few years before the pediatric indication is licensed. It's going to take more years before the enough uptake is taken and herd protection is going to kick off. So in your reflections, think about delaying the potential of herd protection for at least 5, 6 or more years. Thanks. Well, because it's easier. I mean, the clinical, a phase 3 clinical trial with a 3+1 in pediatrics, it takes much longer than a single dose vaccine that will just need to be non-inferior to PCV13 and then to PPSV23 for the.
Dr. Hout from Merck.
Yeah. I was going to make two quick comments and following Dr. Jodar. So the timelines are accurate, and as Dr. Jodar from Pfizer noted, these are immunogenicity studies, so they're not event-driven, so they're predictable in terms of their timeline. And I was going to make the exact same point that the adult indication will come before the pediatric indication. So discussions of how to apply a 15-valent vaccine in adult will come to this committee before you have a licensed vaccine to use in the pediatric age group. Thank you.
Thank you both for your comments. We would like to hear very much from the liaison representatives, the perspectives from their individual groups, please. So let's give me a hand here. American Geriatric Society. Somebody please pass them the microphone.
Thank you. It's Ken Schmader, American Geriatric Society. One point about the shared decision-making I want to make is the health of older adults is quite heterogeneous, and there are individuals where shared decision-making is more challenging. It's patients with cognitive impairment, multisensory impairments, and their caregivers. It's a lot longer discussion, believe me. I will say that, for the record, the AGS supports the continued use of PCV13 in older adults for all the reasons that were listed in that column favoring PCV13 use on that beautiful table you put together.
Dr. Freihofer.
I did.
Oh, I'm sorry, forgive me. The ANA, is that?
Chad Riddle from the American Nurses Association. I'm the one with the blue coat, not the red one. I had communications with the National Black Nurses Association as well as the National Association of Hispanic Nurses in the past couple weeks. Both organizations feel that the current recommendation should be continued. Eric Williams, the president of the National Black Nurses Association, mentioned there's limited awareness in his community about adult vaccinations. There are missed opportunities among healthcare providers. I think that's everywhere. Payment complexities, financial risks for providers to stock and store vaccines, and limited funding for uninsured patients. From Norma Cuellar, president, I hope I pronounced that name right, president of the National Association of Hispanic Nurses, she feels that the 2014 National Health Interview Survey data coverage information showed that the Hispanic population has lower pneumococcal vaccination rates than the non-Hispanic white population, increasing the burden of disease among Hispanics. The Hispanic population is often underrepresented in both statistics and studies completed about the effectiveness of vaccines, and access to vaccines in the Hispanic population is often burdened due to the social determinants of health, provider trust, higher insurance rates, and adequate access to care, among other factors. Thank you.
Thank you. Dr. Foster, and then Dr. Grog. Dr. Foster.
Steve Foster, American Pharmacists Association. First of all, I really would like to commend the committee and the CDC for the amount of work that you put into this. It was quite a burden in 2014 when the recommendation was made, and you guys have looked at many, many different angles and things, so you've done a great job on this. The first thing is that clinicians like to follow guidelines, particularly in the setting that with pharmacy. And by the way, with pharmacy, there are many, many different roles of pharmacists. What we specifically think about primarily in vaccine is the community pharmacists out there. And so by having a guideline, they know what to do and how to implement it. They're very busy. And so when you start getting into decision-making type of issues or confusing issues as far as that goes, they won't vaccinate. In general, clinicians will not vaccinate. It's just they don't have the time to look into it or to go into the details. And we've spent a lot of effort, a lot of resources into actually educating them so they do understand the current guidelines that's going on. The problem with too many changes in these guidelines, particularly if we make a change in one more year and all. It's going to be another difficulty that will be added to that. I was asked to go back and look at the opinion of pharmacists. So I had the opportunity at the American Pharmacists Association to informally poll a group of about 300 pharmacists in there. And what I did is I went through the evidence to framework, evidence to guidelines framework a debate that you guys discussed during the work group, and I presented the data that you presented to them, and overwhelmingly they felt like that because of the fact, again, because there's new vaccines coming, that it would be much easier and much preferred to actually keep the same guidelines and then also change this when the new vaccines are coming up, so it's not as confusing at that point. The main component of this, again, from our standpoint, is the implementation guidelines, the cost that it takes to implement changes like this, more programmatic type of changes versus the scientific changes that go through, though they do understand the cost effectiveness analysis stuff that goes along with this. Thank you.
Thank you, Dr. Grog.
I don't have much else to say now that the others have stated it, but the American Osteopathic Association is in favor of keeping the present guidelines. I give an annual update to our national meeting about ACIP, and I've had enough for the last 3 years teaching them about these 2 pneumococcal vaccines and those kind of things, and if we make changes now, they'll probably throw things at me when I discuss it. So,
Dr. Zahn.
Thank you. This is Matt Zahn for the National Association of County and City Health Officials. So NACHO designated the NACHO Immunization Work Group to review this data and to provide a comment or vote to ACIP. And the ACIP, the work group reviewed the data, and in fact, from Dr. Matnock had a presentation on this topic. And based on that information and review of the data, the NACHO Immunization Work Group recommends that at this point, the ACIP should no longer recommend PCV13 for persons over 65 years of age who are immunocompetent. It is for, I think, the basis was a lot of the same, reasons and conversations that people have had, particularly lack of evidence of population-based disease prevented. And so I think that one of the work group's definite recommendations is what's been mentioned earlier, which is that with any change in this recommendation, that there be aggressive communication both to providers and to local health departments to make sure that we're all providing accurate information and education both to providers and to their patients.
Thank you, Dr. Whitney Williams.
Thank you, Pat Whitley Williams, National Medical Association. We are not in support of keeping, we are in support of keeping the current guidelines. In spite of the impact from PCV13, I wanted to ask you about slides 17 and 18, and they have to do with the population level impact on IPD and IPD-associated mortality, and wondered if you had that breakdown by ethnicity. I also share some of the same comments from the American Pharmaceutical Association, and that sometimes people of color do get both influenza and pneumococcal vaccination at their pharmacies. I don't know if we even know what percent of the population. I suspect it's going to be lower than the numbers who receive it at a provider's office. But I am concerned about, again, risk-based, having that determined at alternative sites outside of the medical home. The assessment of risk, particularly people in that age group with diabetes and other chronic medical conditions, is a concern. Just to consider that the change to no longer recommending the PCV13 to adults over 65 may inadvertently affect persons of color. So I wish you would consider this. I don't know if you've had a chance to look back at slides 17 and 18. Thank you.
Thank you. Dr. Rockwell.
Thanks. Pam Rockwell, AAFP again. For my organization, the Family Physicians, I will say it was a divided opinion. So we did not come to any consensus, but I did give my word that I would say something on behalf of the COPD Foundation. I was approached by the chief science officer to say something about community-acquired pneumonia. And that is something I also feel personally I agree with, that we're not really looking at the effects of this vaccination on the patients who are coming into the outpatient and world and maybe never getting to the hospital, or maybe getting treated and getting better because they didn't get a severe pneumonia. So that is my comment.
Dr. Freihofer.
Sandra Freihofer, American Medical Association, but I'm speaking as a practicing physician. The AMA, as an organization, really honors the process that ACIP goes through in making these evaluations. So I am speaking as an individual. So I've been coming to ACIP meetings since 2006, and I still remember the emergency meeting in which this recommendation was made, and we were looking at the CAPITA study, and when that recommendation was made, it was with the caveat that the information be reevaluated. I think it was in 2018, so we're already a year late at that time. And so we've done this. We have this information up there. I am a practicing physician. Every time there is a vaccine available, licensed by the FDA, I can talk to my patient about it. I have that shared decision making. But what we practicing physicians and what the public depends on ACIP to do is exactly what this work group has done, gone through all the different studies to determine effectiveness and to tell, the practicing doctors who don't have time to do all this if this is something that really works. I wonder what the cost of continuing a vaccine that we don't have evidence for another 2 years is. I would love to have that dollar number. I agree that it's easier to stop something than to add. I want my patients to be protected from pneumococcal disease. I can't wait till this PCV20 vaccine's available so we can look at it. But between now and then, we have resources that we have to distribute most wisely. I mean, we're at a time where we have a healthcare crisis. If we think about the amount of money being spent on healthcare, and we have to figure out how to best use those resources. And I really appreciate all the time that each of you has gone into reviewing these studies, and I trust that you will make the right decision for our patients, for our country.
Thank you, Dr. Shen.
Jeff Duchin, Infectious Disease Society of America. I'd just like to, before I read the official statement from the IDSA, I'd like to thank the CDC team. As someone who previously had the privilege of serving on ACIP, and I know as the current members feel also, it's critically important for CDC and ACIP to be data-driven and evidence-based in our guidance and recommendations. And the IDSA also produces recommendations. We reassess them over time as new data become available and as the epidemiology of disease changes, and we make adjustments to our guidance as appropriate. So with that, I'd like to read you the response of our organization, the Infectious Disease Society of America. And we were asked to weigh in on whether should PCV13 be administered routinely to all immunocompetent adults age 65 and older in the context of indirect effects from pediatric PCV use experienced to date. And after careful consideration of the evidence and the robust discussions made possible by the presentations and the sharing of information that you've heard today with our group, a majority of both our Public Health Committee and our Board of Directors concluded that given the beneficial indirect effects of pediatric PCV13 vaccination on adult pneumococcal disease in the U.S., resulting in a markedly decreased burden of PCV13 preventable disease, administration of PCV13 routinely to all immunocompetent adults age 65 years and older should not be recommended. And the key evidence that we considered in support of our conclusion includes much of what you've seen today. There's no change in population-level invasive IPD mortality or pneumococcal pneumonia incidence after the 2014 recommendation beyond that attributable to the indirect effects from the PCV childhood program, that the majority of pneumococcal disease burden is made up of non-PCV type disease currently, and that limits the benefit from PCV direct effects. That serotype 3 is the most common cause of remaining PCV type disease for which the benefit of vaccination is uncertain, and that it would take an estimated 26,000 adults to be vaccinated to prevent one case of IPD and an estimated 2,600 to be vaccinated to prevent one case of outpatient pneumonia per year, and the very high cost of continuing the current recommendation. The minority that did not support the majority decision raised many of the concerns that have already been discussed, particularly that if potentially increased vaccination rates would result in more noticeable reductions in IPD and IPD-related mortality. However, they recognize the low burden of PCV13 type disease that's preventable currently. They were concerned about the potential for confusion related to discontinuing a recommendation, the administrative burdens, and the subsequent impact on recommendations for a new vaccine. However, in closing, our conclusion is a really reflection of the tremendous success of the pediatric PCV13 vaccination program and its corresponding population health benefits in reducing pneumococcal disease burden among adults. And we would like to respectfully request that if the ACIP agrees and votes to no longer recommend PCV13 be administered routinely, we urge a robust and proactive communication strategy for healthcare providers and the public that clearly describes the rationale and evidence base for this decision. Thank you for giving IDSA the opportunity to provide an official opinion on this important topic.
Thank you. Dr. Weiser.
Thank you. Since the last ACIP meeting, I've had a chance to review some of our data with Indian Health Service, and also been invited to sit in on some of the discussions with pneumococcal work group, which I appreciate. Looking at our data, we have PCV13 coverage for American Indians, Alaska Natives 65 and older that have been reported to our immunization reporting system. Nationally, about 48% have received the vaccine, and it ranges by area from as low as less than 20% to 67%. So there's some either lack of data or differential uptake. We also got to witness some updates to the work that Johns Hopkins has been doing, but there still seems to be a lack of sufficient data specific to American Indians, Alaska Natives to suggest a benefit of PCV13 vaccination of immunocompetent adults 65 years and older. Limited data on American Indian, Alaska Native subgroups do not demonstrate any increase in protection from PCV13 vaccine-type pneumonia or invasive pneumococcal disease beyond the indirect effects achieved with the use of PCV13 in infants. However, those studies are limited to Alaska Native, Navajo, and White Mountain Apache tribes and may not be generalizable to all American Indians and Alaska Natives. Any changes to the ACIP recommendation for the use of PCV13 in adults 65 years and older would have a minimal impact on PCV13 vaccine availability for those higher risk American Indian and Alaska Native adults served by IHS who should still receive PCV13. And finally, we did a quick survey of our immunization coordinators, and overall PCV13 vaccination of adults greater than 65 years of age or greater has been effectively implemented according to ACIP recommendations per their opinions. By a large majority, 92%, these immunization coordinators responded that changes to this recommendation might have a negative impact on American Indian, Alaska Native adults 65 years and older. And I think that reflects some of the discussion we heard from others about the implementation issues. Once they finally figured out how to do this vaccine, then they got used to it and comfortable with giving it in the right sequence and that sort of thing. If you had asked the same question 2 or 3 years ago, you might have gotten a completely different answer. We did not feel that we had enough information to go out on a limb as an agency and say yes or no for which recommendation should be followed, but that's what we've got so far.
Are there any other liaisons that wish to make a comment? Institutions? Okay, then we'll bring it back to the inner table. Voting members, any more comments, questions? Dr. Szilagyi.
Yeah, I'm not. A point that I want to make about the economic analyses, so the number needed to vaccinate or the cost per quality, and it's kind of the same point. So when these models are being done, they don't assume 100% vaccination rates. But so let's say they assume X vaccination rates, but those models are independent of risk. So they're not really modeling shared decision making, if I get this right. They're modeling the total population. So if they're modeling, let's say, a 10% vaccination rate or 30% vaccination rate, that would be independent of risk. So if in shared decision making, and I'm making this point because we're getting into this world of shared decision making, if we can identify high-risk patients, then the number needed to vaccinate would really go down, and the cost per quality would be much lower. If we can't identify high-risk patients, then those models would still apply. So I'm worried that in this conversation with pneumococcal vaccine, it's actually going to be difficult to identify high-risk patients in shared decision-making, so that the number needed to vaccinate or the cost per quality would kind of remain what was in the model. So I don't know whether that was clear at all or totally confused things.
Peter, can I just say one thing about that? In these models, we did assume the current vaccination rate, and I forget the numbers off the top of my head, but close to what we have today. So that is correct. We are assuming going forward the current vaccination rate. It's a cohort looking forward. We did do a little bit of differential risk in that we had separate groups for those who were healthy, and I recognize that that's not a great term for describing an 85-plus-year-old. But we did separate out that group from those with chronic medical conditions, those with heart, lung, liver disease, alcohol abuse, et cetera, that are not covered in the immunocompromising recommendation, as they don't receive PCV 13 by the immunocompromising recommendation. They should receive PPSV 23 in that 2012 recommendation. So not sure that clarified anything since, but.
Dr. Lee.
Yeah, I just wanted to agree with Dr. Madanach that the models did incorporate it, but what you're seeing is essentially a pooled estimate. But there was some differentiation in the populations with differential risk associated with it. That said, one actually maybe broader comment I'll make is that, and it doesn't necessarily answer your question exactly, but I think, again, as we're trying to understand this construct of shared clinical decision-making across a series of decisions, not just this one, but more broadly. Two things. One is from the pharmacy perspective, it is true it's shared clinical decision-making, but on the other hand, if a patient walks into a pharmacy and says, I know I want this vaccine, to me, that seems like it's a reasonable thing to administer a vaccine if the patient feels they're well informed and they want to go ahead and get it. I don't think I necessarily have a problem with that. So I guess it depends on how you define the construct of shared clinical decision making. Does it require a conversation between two people? Obviously, we want to make sure people are informed, but I think there are multiple ways people can be informed. I don't think people are only informed through their healthcare provider. So that's point number one, and then maybe you can respond to that. And then the second comment is that I realize we haven't discussed this yet, but from the flu perspective, there was a really nice summary of recommendations that actually spoke to the fact that while we recommend universally influenza vaccine for anyone 6 months and older, in constraints or resource-constrained settings, there was actually a really nice sort of framework for thinking about how to prioritize, in no particular order, people who might be at higher risk. And every given season, we are essentially doing this for all all of our patients based on sort of when flu vaccine becomes available, who you're seeing. So I think that that dynamic decision-making is essentially happening. And as I was looking at that sort of flu construct, it made me realize, we really need to think about we treat these vaccines in isolation, but much like I remember years ago, Dr. Middleman mentioned an adolescent vaccine platform, and I remember thinking, oh wow, what a great concept. I think we kind of need something like this for the adult, pneumonia prevention platform or whatever you might call it, because I think that there's a lot of interrelatedness, yet we treat them separately and we're trying to make these decisions separately, but we're trying to protect the same population. I don't have an answer for today, though, for how we get there.
Any other questions or comments from the work group?
Veronica McNally. I think what I'm struggling with is that the public trust in this organization is that we're making decisions based on current data, that it's the most up to date. And I don't want this current data to erode the trust that we have in other vaccines and the importance of them at the time. So I'm really thinking about that. And I appreciate also the use of resources and the fact that we don't anticipate that future introduction of vaccines will really change the outcome in terms of the population level impact.
Thank you. Any other comments? Dr. Stevens.
I think the issue, in my view, is about pneumonia and the prevention of.
I just wanted. All right. There was data provided to us in the printout, in the handout, that indicated that the estimated cases averted of pneumonia per both cohort, 65 years, was 4,000 to 10,000 for PCV type pneumonia. Is that data? We believe that that's the correct data that you're providing?
So in your handouts, and so you can look at it, there should be two slides. In the presentation, there was the annual numbers needed to vaccinate.
Right.
As well as there should be included in what was posted today a backup slide, which is the number needed to vaccinate for a cohort 65 plus. And I think it's important to note, and it's been brought up, I think, before here, that the annual number needed to vaccinate is different than the number needed to vaccinate for a cohort, because for a cohort, then you get the benefit of that vaccine for whatever the assumptions are in the model. Those come from the same health economics model.
But to the point that there are several thousand cases, if we decide not to use this vaccine anymore, you're proposing that in that particular cohort, there would be up to 10,000 additional cases of pneumonia over the lifetime of that cohort.
Exactly. That's the difference between using PCV 13 plus PPSV in series versus PPSV alone. Your interpretation is correct, yes.
Dr. Foster, would you like to comment?
I'd like to respond to Dr. Lee just for a second. You have to keep in mind that, first of all, state practice is what monitors or decides what pharmacists can actually do, and every state has their own boards that decide what is happening. We operate under standing orders. So standing orders are something that says we can or can't do or do that, and typically the standing orders say follow what ACIP guidelines say. So if it's not a clear follow ACIP guidelines, it may not happen, even if they walk in and ask for it.
Are there any questions or comments from either the voting members or the liaison representatives? Dr. Moore.
Just a brief comment. As I've had more time to reflect, it seems that part of our dilemma is that we have two main choices. One, prioritizing operational concerns, being don't change anything, and the operational evidence. And then the other, which is remove the recommendation, which prioritizes the epidemiologic evidence. And I think our struggle is that both are legitimate points of view with very legitimate questions to be answered. And I think the shared clinical decision-making is an attempt to split the difference. I do have some concern, though, that it could inadvertently make things more complicated. But as I'm reflecting more, I'm seeing, the operational versus the epidemiologic, and both are legitimate, and I think that's why we're hearing the dilemma we're hearing today. Thanks.
Thank you. Dr. Maldonado.
Hi, thank you. I'm a pediatrician, so I had avoided making any comments until now, but it just seems, I'm glad you brought that point up, Kelly, because I was thinking about this over the lunch break and also looking at the literature around the epidemiologic evidence. And I also think that if you're looking at a vaccine from an effectiveness standpoint, I think, we're looking at two different things here. One is the vaccine efficacy/effectiveness versus what's the population benefit. And obviously, if it's an FDA-approved vaccine and it's efficacious, the question is, what's the vaccine efficacy? What are the direct effects of the vaccine subtracted from the indirect effects? So, for example, is there a population for which the direct effects are actually going up or stable? Because I think there's additional information that maybe we're not seeing around if you're just looking at the indirect effects. It may be that the direct effects aren't being masked by that. So what you need, and you need a control group. You need the group that was vaccinated who didn't get sick in order to show the direct effects. And I don't think we've seen that. Or maybe you have and I just missed it. So I worry a little bit about that around identifying populations, especially when we talk about populations that may not be vaccinated appropriately, and you're looking at, are there pockets where direct effects are showing some impact on the disease. The other issue I wanted to bring up is I also looked at a meta-analysis around the effect of herd immunity on adult IPD. And the data suggested from this meta-analysis, recent, that it takes about 2 to 3 years for this PCV13 predicted to reach a 50% reduction in disease, but it would take about 8 to 9 years to get to a 90% rate. And I can share that reference with you. So I'm wondering if it's a little early maybe to really see what's going on and whether that number is still going to drop further. But even that doesn't clarify the issue of the direct versus the indirect effects. So they're two separate issues. Thanks.
Thank you. Okay, any other comments? Almia? Dr. Manatak?
I'm happy to give a brief point about that, is that we have seen from effectiveness studies, effectiveness of this vaccine. We have at the population level seen no impact, meaning that both we have not seen any continued indirect effects, nor have we seen any direct effects at the population level. And we are, as you're pointing out, I think rightly, we are now close to 10 years after interdosing PCV13 and more since conjugate vaccines have been used for children.
Dr. Massinier.
Actually, Dr. Mann.
Barbara Mann, Director of Division of Bacterial Diseases at NCIRD. I just wanted to mention that, there are, in the space of shared clinical decision-making, it would be possible to identify some groups that would be at higher risk that would provide some assistance to clinicians if the committee decides to go in that direction.
Any of the voting members or...
Just a question. So will the group that you're going to provide different from those groups that are excluded already with the high-risk group? Is that different group?
So the group that meets the definition of immunocompromising conditions isn't part of this policy decision. Yes. So that group will be recommended to receive both vaccines regardless.
Okay.
But if the committee decides to go to shared clinical decision-making, and then guidance needs to be developed, some sort of wording about how clinicians and patients would think about this, there are additional data about groups that are at higher risk that could be pulled together to assist.
So there will be two groups that they have to consider. The group that we didn't consider, which are the group with medical conditions, and then there will be this high-risk group again, if we go that route.
I guess what I was trying to make is the parallel between the HPV and the HPV discussion. The HPV work group put up some clinical considerations language with the idea being that language would be provided in a different fashion to clinicians so that we could provide some help to clinicians in how they would think about this. The pneumococcal group didn't put up that kind of language, but there are clinical considerations. It wouldn't be ACIP recommendations. It would be clinical considerations that we would provide. And so I guess what I'm saying is it wouldn't just be number B. There would be more that we would be providing to clinicians so that it's not just go, it's here's how we would help think about it.
Dr. Manitok, you wanted to clarify?
Yeah, thank you. Sorry, I just wanted to bring up one point that was raised before about disparities, because we do have a little bit of information about that and have shared that here. So I'm sorry, I'm giving you a headache by clicking back through here, but we presented here the disparities by race and ethnicity that we have looked at. And the graph, if I can pull it up, showed that indirect effects amongst older adults of Black race, the disparities have been eliminated through indirect effects. The disparities for Alaska Natives and, in this case, Navajos was the population looked at, have been reduced through indirect effects, but not completely eliminated. So that point was brought up before, and I just wanted to make sure that is known. I understand it's an important point that we continue to assess because there's other factors of access and other issues around this, but we do have some data about that. Thanks.
Thank you. Any other comments from the voting members? Comments from the liaisons? Dr. Jordar, you had a couple of comments quickly. 1 minute. Please take a minute to do so.
I agree with all of you that this discussion has been about the epidemiology viewpoint versus the programmatic and the programmatic issues, the implementation issues. Therefore, as representative of the manufacturer, I'd like to discuss a little bit about the epidemiology viewpoint. Dr. Madranok, if you can put slide number 13. Well, sure. I think in that slide you had a 6 to 11% in all-cause pneumonia, which that has not been considered in the discussions. That's around 30,000 hospitalizations that the CDC data. And that was not included in any of the cost effectiveness calculations. So I think it's important when we say that there is no public health impact, this is a gigantic public health impact that, by the way, it's not isolated. It has been corroborated in Germany and in the Netherlands. And the last comment is about numbers needed to vaccinate. There was a lot of technical discussions about number needed to vaccinate. In all these models, number needed to vaccinate was for 1 year. This vaccine, as a conjugate vaccine, has shown at a minimum 5 years protection. So those number needed to vaccinate might need to be divided by 5 to really have a real picture of what number needed to vaccinate. So when we talk about public health impact, I think this consideration should be taken into account by the committee. Thank you so much again.
Thank you for limiting your comments. Thank you. Okay. If there are no other comments from liaisons or the voting members, we'll go ahead and take motions. So, open for motions. We have 2 motions on the table at the same time. I will allow Dr. Lee to go first.
Well, I'll just say that while this is a difficult decision and there are 3 different viewpoints on the table, I do think that because of the way the PICO question was asked and the way we've reviewed the evidence, that it makes sense to me to evaluate option A, which is ACIP recommends. So I move that we vote on ACIP recommends PCV13 for all adults 65 years or older who have not previously received PCV13.
We have a second motion by Dr. Hunter. Dr. Hunter, please go forward.
Yeah, I would like to motion C, no longer recommend PCV 13. The ACIP no longer recommends for adults 65 years and older who do not have immunocompromising conditions, but that they should continue to get PPSV 23.
Okay, so for the audience to clarify, so when this happens, we refer to Robert's Rules of Order, and the motion that would move forward for seconding at this time would come from the chair of the work group, which would be Dr. Lee. No, you can't. No. So does anyone want to second the motion from Dr. Lee? Dr. Atmar.
I second the motion.
All right. Any discussion, comment?
So just to remind everyone, we're going to, the motion and a second has been put on the table. We're going to stay the motion and go into the next session and then have public comment and then come back. And further votes can be considered if the first motion does not pass at that time.